Hello and welcome to ASE's Guideline Webinar Series. I am Liz Lane, ASE's Online Education Specialist. Today's webinar is titled Overview of the 2019 ACC AHA ASE Advanced Training Statement on Echocardiography. Without any further delay, let me introduce today's speaker. Dr. Susan Wiegers received a BA in Physics from Cornell University with distinction in all subjects. She was an AOA graduate of the University of Rochester School of Medicine and Dentistry prior to her residency in internal medicine at Strong Memorial Hospital and a fellow in cardiology at Boston University Medical Center. Dr. Wiegers completed additional fellowship training in echocardiography at the Massachusetts General Hospital. Prior to accepting the position of CEO of the Temple Faculty Practice Plan and Senior Associate Dean of Clinical Affairs at the Lewis Katz School of Medicine at Temple University, he held the position of Senior Associate Dean of Faculty Affairs for 7 years. Dr. Wiegers was the Director of Echocardiography Laboratory at the Hospital of the University of Pennsylvania for 10 years, and previously was the faculty of Boston University and Boston City Hospital. Dr. Wiegers has published 3 books on clinical echocardiography and multiple scholarly publications. She is a past president of ASE and the recipient of the Richard Popp Excellence in Teaching Award. She recently was the chair of the writing committee for the ACC AHA ASE Advanced Training Statement on Echocardiography, along with past President Thomas Ryan, who served as co-chair. It is our pleasure to have Dr. Wiegers with us today.
Good morning, everyone. Thanks for joining me. I'm going to go through the document and explain its origin and the purpose of the document. And then at the very end, I'll answer any questions that you have. I have no financial conflicts related to this presentation. First of all, I'd like to thank the writing group. I was the chair. My co-chair was Tom Ryan. Jim Origi was the leader from the ACC Competency Management Committee, and I'll tell you about them in a minute. And then we had Sam Brown, Barry Canaday, Julie Damp, Jose Diaz-Gomez, Mario Garcia, Linda Gillum, Brian Griffin, Jim Kirkpatrick, Kylie Klarich, George Liu, Scott Moffitt, Tasmin Naqvi, Amit Patel, Marie-France Poulin, Jeff Rose, and Madhav Swaminathan. The ACC Competency Management Committee are the ones who commission the advanced training documents, the COCATs, as well as the lifelong learning competencies. And you see all the members here. The society representation on the writing group was quite robust. The ASE had 3 past presidents and its president-elect, 4 board members, and many members. Also, there were representatives from the American Thoracic Society, the Society of Critical Care Medicine, the AHA, the Society for Cardiovascular Angiography, the Society for Cardiovascular Anesthesiologists, the ACC Competency Management Committee chairs, and the cardiovascular program directors. Many of these people, such as ATS and SCI, are not cardiologists, but we felt it was important to have a broad range of input, even though this training document relates only to cardiologists. I also would like to acknowledge that Debbie Agler, RDCS, was a member of the writing committee from October 17th to March 18th. She has been on the executive board of the ASE. She made many outstanding commitments, contributions to the document. Unfortunately, or fortunately for her, she took a job in industry, and ACC does not allow industry participants on writing committees. So she is not listed as an author, but she certainly was a contributor. Here's a link to the document. You'll be able to see that in PDF. And there also is it will be published online in JACE, along with an editorial that Tom Ryan and I wrote about the competency statement. So competency-based education is not new, but something certainly different than when I trained. It means having the necessary ability, knowledge, and skill to do something successfully. Some people argue that this should be called proficiency and not competency, but certainly expertise is what we're after in advanced training. Competency-based education has replaced knowledge objectives, the old standards that we had, and it's more focused on outcomes and demonstrations of ability. It's been adopted by both the LCME and the ACGME for goals of medical residency and medical school curriculum. The ACC established competencies for adult cardiovascular fellowship first in 1995 with the COCATS document, which interestingly stands for Core Cardiovascular Training Statement. There are 3 levels of training, I'm sure you all know. Level 1 is basic exposure to a field required of all trainees to be competent cardiologists. Level 2 is additional training necessary to develop competency in specialized areas that enable a cardiologist to perform or interpret specific studies or render specialized care. Level 3 is advanced training in specialized areas that enables a cardiologist to perform, interpret, and or train others to perform specific procedures or clinical activities at a high skill level. COCATS 4 was published in 2015, and it focused primarily on level 2 training for all competencies. It made the statement that level 3 training in any field would require additional years of training, but ECHO was given an exception. If all the elective time were used, level 3 training could be achieved within the 3-year general cardiology fellowship. And we'll talk about how that can be done. And COCATS 4 envisioned this advanced training statement in echocardiography following after it to define level 3 training. So why is an ATS document on echocardiography necessary? Note that there have been 2 other advanced training documents already published, one on clinical electrophysiology and one on advanced heart failure and transplant. And in addition, the ABIM recognizes and certifies cardiologists who have completed training in general cardiology and then advanced training in heart failure and transplant, adult congenital heart disease, which is a 24-month requirement, clinical cardiac electrophysiology, again, a 24-month period, and then interventional cardiology, which is currently 1 year. Neither ABIM or COCATS define level 3 training in echocardiography. The first exam in clinical echo was given in 1995 as a field test by ASE. And then ASE Exam Inc. gave the test in 96, 97, and 98. I took the first test in 96 and have a remarkably low certificate number. Since 1999, the test has been given by the National Board of Echocardiography, and it began offering certification in echocardiography starting in 2001. The current requirements for certification include completing level 2 training in echo during a fellowship. In the old days, NBE used to define what level 3 meant, but they no longer do. They only require level 3 training, level 2 training to take the exam. So who certifies someone as level 3 in echo? Some people think it's the ASE, some people think it's the ACC, some think it's the ABIM. It's basically the Echocardiography Program Director in conjunction with the General Fellowship Director. They are the only people who can say somebody's level 3. Taking and passing the NBE exam is required, but it's not sufficient for level 3 training. And this, in my mind, is the primary reason that we needed an advanced echo training statement. What is the difference between a level 2 and a level 3 trained echocardiographer? Let me acknowledge in some cases absolutely nothing. There are a number of level 2 trained faculty who are experts in echo and really have contributed to the field. But in general, level 2 echocardiographers interpret echoes as an integral part of their practice of clinical cardiology, whereas level 3 training goes beyond level 2 in order to gain competencies in specialized ultrasound techniques, complex studies in special patients, and specialized care. Level 3 training also prepares fellows to engage in research, train others in the field, and direct training laboratories. Level 3 trained individuals have echocardiography or multimodality imaging as the primary focus of their careers. And that's what is envisioned in this advanced training statement document. So what is required to have a program that can certify people as level 3 trained? First of all, and you'll find this in the document in the text, training should occur at an institution with an accredited cardiovascular training program. The writing committee did not envision that this would be a training program that was unconnected to a general cardiology training program. The echo training program occurs in a lab that must be directed by a level 3 trained NBE certified echocardiographer. The echo program director also has to be level 3 trained and NBE certified. And in many situations, the program director is the lab director, but this is not a requirement. It is recommended that all of the faculty be NBE certified and that the majority be level 3 trained. Faculty should be engaged in scholarship, which we broadly defined as teaching and/or research. Let me point out that experienced sonographers are essential to a level 3 training program. We need experienced sonographers who are expert in the field and committed to training fellows in image acquisition, optimization of machine settings, and contrast images. Speaking for my sonographer colleagues, I'd like to point out that sonographers must be given time and recognition for their efforts in training the fellows. Being expected to do 15 full clinical studies a day and train the fellows on the side is not supportable. Additionally, sonographers should have access to educational opportunities, not only to advance their skills in echocardiography, but to advance their educational skills. And finally, experience with hand-carried ultrasound is extremely desirable, and it may be taught by sonographers or other POCUS-trained faculty, including critical care, thoracic, anesthesia, or emergency medicine physicians. The lab itself must be accredited by the Intersocietal Accreditation Committee in ECHO. You must have up-to-date ultrasound equipment, online or offline workstations for 3D and strain analysis so that trainees can manipulate images and render analysis. There must be an ongoing QA program with correlation of results from other imaging modalities. Simulation training may certainly enhance education, but it is not required and may not be substituted for procedural numbers, and we'll go over those later. And exposure to other multimodality imaging, cardiac imaging, is required, and it is recommended that this be at the level 3 trained imagers in other modalities. Additionally, the advanced training statement envisions that there is a broad range of pathologies available for inpatient and outpatient experience. The committee thought that it was unlikely that institutions with less than 7,500 cases annually would have a robust enough clinical exposure to train a level 3 echocardiographer, but this was not made an absolute requirement. Furthermore, we acknowledge that outside rotations at other sites for example, for exposure to adult congenital heart disease, may be required. The quality of the program, of the outside program, is the responsibility of the echo training director. The educational program at the outside facility must be directed by a highly trained echocardiographer. But IAC accreditation is not required for outside rotations if they constitute a small percentage of the training. Remember, there currently is no certification exam for pediatric echocardiography, and some of the adult congenital experience may take place at a pediatric site, and that's why these requirements are waived for outside rotation. Other outside rotations might include sites that use ventricular assist devices or ECMO, or places that do structural heart disease interventions. I'm sure you all know, if you're involved in training at all, that there are 6 competency domains recognized by the LCME and the ACGME and used in these competency documents by the ACC. These include medical knowledge, patient care and procedural skills, system-based practice, practice-based learning, professionalism, and interpersonal and communication skills. The ACC has developed competencies for the last 3 that apply to all cardiologists, and they're pretty similar between the advanced training statement documents. But here's an example of the medical knowledge competencies. This is table 1 in the document. So if we look at medical knowledge on the top bar in gray, when we go over to milestones, you see that there's a column all and a column add asterisk, which means additional. So all means that this competency is required for all level 3 trainees. Know the physics of ultrasound, including understanding of optimal machine and transducer settings, the effective change in frequency of transducer and transducer types, and effects on a resolution, temporal, lateral, and linear. Know the basis of image formation, beam focus and resolution, cause of artifact, etc. These are general physics knowledge, but are advanced and specific. Under hemodynamics, these refer to all diseases. Know the normal cardiac physiology and the pathophysiology of diseased cardiac states. Know the echocardiographic correlates of pressure assessments in the heart, including complex valvular lesions and diastolic assessment in complex disease. Know the limitations of various hemodynamic measurements and how to reconcile discrepant indices. Know complex and advanced hemodynamics and the relationship between Doppler findings and other imaging and invasively measured intracardiac pressures. Now, there are, continuing in medical knowledge, general competencies for all conditions. And these, I just want you to review them briefly. Know the echocardiographic findings of simple and complex acquired disease, including postoperative. Understand the principles of the hemodynamics. Know the advantages and limitations of echo in relation to other imaging modalities. Know the correlation of echocardiography with other non-invasive imaging modalities and invasive assessment. Know the causes of discordant findings and procedures to reconcile those differences. Know the limitations of all imaging and invasive assessment and appropriate use of imaging in each condition. Know the importance of serial comparisons and principles of assessing serial change. And know the indications for emergent and urgent patient evaluation. These general competencies then apply to each of the medical areas for medical knowledge. And these include ventricular disease, including assist devices, advanced heart failure, atrial anatomy and physiology, pulmonary hypertension, valvular disease, pericardial disease, stress testing, disease of the aorta, adult congenital heart disease, critical care and perioperative disease, and research. Let me give you an example where a competency is not required of all, it's additional. And this is under ventricular function. Know the imaging approaches, TTE and TEE, for assistance of veno-arterial and veno-venous extracorporeal membrane oxygenation cannula placement, and for confirmation of appropriate position at any point in time after insertion. This was considered an additional competency because not all institutions do ECMO. And so it is not a required component of level 3 training. But if someone is going to consider themselves competent in the evaluation of ECMO, these are the things they need to know. Similarly, under patient care and procedural skills, we have a number of obvious procedures, TTE, TEE, 3D, render strain images offline, render 3D images offline. But there are additional milestones that could be met. Skill to acquire and interpret images to assist structural heart interventions. Skill to acquire and interpret and diagnose adult congenital heart disease and assist in interventions. Skill to guide insertion of mechanical support devices, including surgical and transcatheter devices. And skill to assist in the performance interpretation of intracardiac echo during structural or electrophysiology procedures. To emphasize again, these are not required, but these are additional competencies that some level 3 trainees may wish to acquire. And this lists the competencies. It is thought, if you look here at the difference between 9 and 11, skill to acquire and interpret echocardiographic images to optimize temporary and permanent ventricular assist devices and to diagnose device and malfunctions is required of everyone. If your site does not do LVAD, then it will be necessary for the trainee to get experience either at another site or through another mechanism. It's thought that all level 3 echocardiographers should be able to diagnose LVAD dysfunction because you never know what's going to hit your emergency room. But we recognize that inserting left ventricular assist devices and managing placement is a different character, and that is then an additional or optional requirement. So let's move on to the required procedures. Transthoracic scanning, the level 3 trainees should be at the level of expertise to train other fellows and sonographers in acquiring high quality images and troubleshooting poor quality images. Clinical experience in hand carried ultrasound and the ability to perform emergency echo interpretation in hemodynamically unstable patients is an expectation. Again, transthoracic interpretation must include a very broad range of pathologies. And it must include contrast studies for interpretation. TEE must also be complete studies on patients with a broad range of pathologies. Stress echocardiography must include a sufficient number of abnormal studies, as well as studies done to assess valvular lesions, pulmonary hypertension, and diastolic function. Reading a bunch of normal stress echoes is not going to make somebody competent or proficient at interpreting stress echo. Contrast must be used on cases with inadequate endocardial imaging. This is a requirement of IAC accreditation and shouldn't be a surprise to anyone. 3D must include image rendering and manipulation, including valvular assessments, as well as ejection fraction and ventricular volumes. The 3D echo must be both TEE and TTE. And strain rate quantification, again, must include image rendering. So here is table 2, which is the procedural volume, and lists the number of things that are required for training to level 3. Let me first emphasize that this is the minimum procedural volume typically necessary for the development and demonstration of level 3 echo competencies. It comes with a footnote, and we'll go back and discuss the numbers in a second. The numbers are based on consensus and intended as general guidance based on the needs and progress of a typical level 3 trainee, and represents cumulative experience during the entire training time. So if somebody's in a 4th year level 3 training, the studies that they did and interpreted during their 3-year general fellowship, or if they're in their 3rd year during their first 2 years, also count. The things that they counted to get to level 2 count additionally towards level 3. They're just more requirements. Again, we suppose a broad range of adult ages, genders, pathologies, and including mechanical heart disease, circulatory support devices, contrast echo, and 3D. A range of exposure must include a broad range of indication settings and pathologies, operative and intraoperative studies, and exposure to strain and 3D is expected to occur during the course of TEE, TTE, and stress studies, not additional requirements. And we'll go back to look at the numbers in a second. So here are the numbers. The good news is that there is no additional scanning required beyond the 150 full and complete studies that are expected for level 2. We thought there's so much to learn in level 3 training that scanning an additional 150 studies, which was the previous number that was promulgated for level 3, was unreasonable. Rather, the competency is not that you can image the heart, but you can expertly image the heart. Some fellows will require more scanning time, others won't. 750 transthoracic echoes interpreted, again, a broad range of pathologies, not normal studies. This represents an additional 450 beyond level 2. So 450 may have been done, 300 may have been done during level 2 training. The expectation is that you would have completed 750 to reach proficiency for level 3. Transesophageal echoes performed and interpreted as 150. And then 3D echo, 50 TE or TTE to evaluate valve disease. Again, these 3D echoes are done during the transthoracic interpretation or the TEE, performance and interpretation. 50 should be done transthoracically for ventricular volumes, function, and ejection fraction. Contrast echocardiography should be at least 100 studies. And again, during transthoracic, stress echo, and less frequently, transesophageal echo. Strain and strain rate quantification, 50. And then the stress echoes must include 25 for non-coronary indications, such as diastolic function, pulmonary hypertension, or valvular heart disease. Where did these numbers come from? Previously, we looked at the previously published competency statements, including the NBE old requirements. The writing committee had extensive discussion, and it's a consensus expert opinion. We did, after we reached our numbers, survey the 234 ABIM recognized cardiovascular fellowship program directors, of whom 67 responded, and surveyed 25 imaging directors, of which 11 responded, and most were agreed. There was a consensus that the numbers were reasonable. There were 600 public comments during the public review period that were all answered, and many of them centered on the numbers and et cetera. But please note that procedural volumes are proxies for acquiring the technical proficiency and analytic skills essential for the clinical mastery of echocardiography, which is the fundamental objective of advanced training. A trainee, if they're having trouble with strain or contrast or scanning, may require more than the minimum recommended here. The procedural volume are only proxies for the competency, and it's the competency that we're trying to acquire. So some frequently asked questions. Can two fellows interpret the same transthoracic study? Yes. If they separately generate a full report that is reviewed by a faculty member. That's a lot of contrast, some people said, but it's only 10% of the TTE and stress volume, which is on the low side for estimated appropriate contrast usage, which is in the 20 to 30% range. Can two fellows do the same TEE? No, not fair to the patient. Can any TEE count towards procedural volume? Only if the study is complete. A quick in and out to look at the left atrial appendage before cardioversion is not a full study. And can a stress echo be counted twice, once as a stress and once as a TTE? No, not unless they're absolutely full studies. Now let's move on to the additional and optional procedures. And I've written additional and optional in red because this point has not been clear to some people. The special procedures are not required for level 3 training, but a level 3 trained person who hasn't done 30 structural valvular interventions really can't be considered competent at those interventions. This table also comes with a footnote. Note these are not required for level 3. The procedures can be counted towards TTEs or TEEs provided that a complete study is performed. And a level 3 trainee should perform right and left-sided procedures if the goal is to obtain competency in the full range of structural interventions. So there are the numbers, again, minimum procedural volume typically necessary, 75 interventional procedures, 30 structural valves, 10 transseptal catheter guidance, 15 closure of septal defects, 10 alcohol septal ablations, 10 left atrial exclusion, left atrial appendage exclusion, 20 ventricular assist device placement and assessment. Remember, this was an additional procedure listed in the competency list, not a required one. Intraoperative echo, these numbers come from the perioperative guidelines, 75. 50 of which must be surgical repair or valve replacement, and 10 intracardiac echo. Not all echocardiographers do intracardiac echo, but some of us do. But you can't wing it. You have to have actually done some and been trained to it before you can be considered competent. Special procedures is an evolving field. There are new procedures every year, and so this should be seen as a suggestion and not a requirement. There are things that will be happening in 2 years that we don't know yet. Level 3 training does not automatically mean a trainee is competent at all of these special procedures. Lifelong learning with maintenance of competence and development of new competencies is the expectation. A perioperative echo should be trained under the direction of an NBE certified anesthesiologist and requires understanding not only of the TEE findings, but the surgical techniques, the impact of anesthetic agents on hemodynamics, and the management of complications. Fewer trainees choose to train or be certified in perioperative echo, as many programs now, this is solely the purview of the cardiac anesthesiologist, but that's not the case everywhere. In terms of research and scholarship, skills necessary for level 3 include research and educational expertise. Original research and mentorship by academic faculty is preferable, but in programs not designed to support original research, participation in QI and educational projects, journal clubs, and scholarly presentations is expected. Public comments were varied on this requirement. Many people said level 3 training should include a full year of just research, and some people said there's no reason a level 3 person should do any research. It is an expectation that the level 3 person will engage in scholarship, again defined as either original research or educational projects, teaching, journal club, and scholarly presentations. But lifelong learning is the ongoing expectation. Now, the goal of level 3 training depends on the individual trainee's goal. They may aspire to academic research, educational leadership, laboratory leadership, policy leadership. The advanced training statement is intended to foster flexibility in training rather than a one-size-fits-all approach. How do we measure proficiency? All general cardiovascular fellowships have competency committees that regularly assess the individual trainee's progress. The time commitment for accurately assessing proficiency is not insignificant for the faculty. You have to observe scanning, review studies, review reports. You need to observe the quality and helpfulness of the trainee's communication with referring physicians and inpatient teams as they explain the clinical relevance of the echo findings. It requires honest and open feedback to the trainee. Many programs use in-service quizzes, and of course the NBE exam is required but not sufficient. General cardiology fellowships are now a 3-year standard fellowship. It's funded in part by funds from CMS paid to the hospitals for GME slots. You can't use GME slots for unapproved training, which would be a 4th year of echo training. Many hospitals are over their cap and fund GME slots themselves, but they need to see a return on investment. And unfortunately, it is not many CEOs of hospitals or health systems who view a year of echo training, an additional 4th year, as having any return on investment. The ABIM has recognized 4th and 5th year training for advanced heart failure, electrophysiology, interventional cardiology, and adult congenital heart disease. So here are some pathways to receive advanced training in echo. If the trainee devotes all of their elective time during their 3 years, they can meet these requirements and procedural requirements. It does require a decision early in the career, early in the training. Several institutions, many of the larger academic centers, have training grants that fund 4th and 5th year training in echo or multimodality imaging. At Penn, we had a system of hybrid instructor and fellow positions. So the instructor would be an attending in clinic and the CCU, for example, but would be a fellow in the echo lab as they completed their echo level 3 training. And then there's the possibility that private or industry funding could fund fellowships. It's about $100,000 a year for salary and fringe for a PGY7 fellow. And it's not a conflict of interest as long as industry does not select the fellow. So in conclusion, this advanced training statement is meant to provide a roadmap for level 3 training rather than a strict formula. The procedural numbers are expected minimum required to gain proficiency. Fewer or many more than these numbers may be required based on the individual trainee. The document envisions a road to level 3 for level 2 trainees who are in their early post-fellowship years and join a lab where they can be trained under appropriate supervision. And COCAS, along with ATS and lifelong learning competency documents, are meant to span your entire career. Thank you for your attention. And now I will move to the questions. The first one, when does this start? Does it apply to fellows finishing their 3-year fellowships next month? Tom Ryan and I wrote in our editorial for JACE that we do not see that would be particularly fair. But it is up to the individual training, ECHO training director and program director, whether they are going to apply these competencies suddenly to those trainees. This document is only published online. It has yet to appear in print in JACE or JAC, and it seems a little presumptuous to inflict this on the current 3rd-year fellows. My institution meets all the criteria, but we don't do TAVRs. Does this mean we can't offer level 3 training? No. As I pointed out, level 3 training, TAVR is an additional optional procedure. It's not required for level 2 training, for level 3 training. You do need to know how to evaluate prosthetic valves, whether they were put in transcutaneously or surgically, but it's not a requirement that we do structural heart disease to achieve level 3 training. Will there ever be an ABIM-approved echocardiography or imaging pathway? This is a very controversial question. Thank you for asking it. We should be careful what we wish for. The advantage of having an ABIM-approved echocardiography or multimodality imaging pathway would be that GME funds could be used for a 4th year of training. The disadvantage is that most hospitals are so far over their cap, it really wouldn't matter very much. And if we were under the ABIM, echocardiography would fall under ABIM MOC rules, which it currently doesn't. There is a re-exam every 10 years for the NBE. I've taken it 3 times. I'm debating in 2027 if I'm going to take it 4th time. But there's no MOC requirements, and as you know, the ABIM requirements have been extremely controversial.
Okay, if there aren't any other questions, we can end today's session. Thank you everyone for participating in today's webinar, and a very special thanks to Dr. Wiegers for presenting on behalf of ASE. Be sure to keep up to date on future live webinars by checking the ASE University homepage. Thank you again and have a great day.
Thanks everybody for your attention.